jump in. If you are on Facebook, please join us. We're going to be getting started in just a few minutes. So okay, and people are jumping into the webinar format. For those of you joining us on the webinar, thank you so much. Remember, that is a separate link that you were sent through the TAPUnlimited newsletter. And if you did join on there, you will see at the bottom that there is a room for chat, and there is also a Q&A. You can put questions, comments in either of those areas. After Dr. Rose's presentation, which will last about 30 minutes, she has graciously offered to join us for some questions. If you have any stories you want to share or questions about her presentation or about stroke in general or your stroke, that would be great. I'm sure she would entertain those. So through all of these TAP talks, which we are doing monthly, I have realized that I need glasses because every single time I'm squinting to see what time it is, but it is just about 6:30. So I am going to go ahead and welcome you all who are joining us on both Facebook and through our webinar format. I am so excited today because there are people that you meet in this field that you just connect with, that you understand gets it, both from personal and professional ways. And our executive director, Justine Knight, had introduced us to Dr. Deborah Rose, and I asked if we could chat. And I think we could have talked for probably 2 hours, would you say, Deb?
Absolutely.
We both had a lot of things in common, some ideas and thoughts and experiences. And I'm just extremely glad that she has agreed to present to us today, especially because this is May, which is Stroke Awareness Month. And next month is National Aphasia Awareness Month. So we've got lots to make aware and celebrate and advocate for over the next couple of months. So without further ado, I would like to welcome Dr. Deborah Rose to TAP Talks, which is our monthly gathering. Dr. Rose, you have such an impressive background already in the field. And I was wondering if you just could introduce yourself and kind of how you got here, and that would be great.
Sure, absolutely. Well, thank you so much, Mara. And I'm also very grateful to Justine and the rest of your team for this opportunity to be here and share as much as I know and I can about stroke. I'm really excited to be speaking with everyone on this call. I'm Deborah Rose. I am a second-year neurology resident at Duke University Hospital. I'm originally from New Jersey, and I kind of did I had sort of like a triangle of an experience where I went from New York to Chicago for medical school, and now I'm down here in the South in Durham doing my neurology residency, and I'm so excited to be here. This is a topic that's very near and dear to my heart. I do have a deep interest, particularly in dementia and Alzheimer's disease, but especially also in post-stroke cognitive impairment and in educating patients about the importance of stroke prevention, either primary or secondary stroke prevention, and the importance of recognizing the signs and symptoms of it. So the patient can present immediately to the emergency room for evaluation. So that's a little bit of what we're going to be talking about today.
I think that's so great that you are sharing about the signs and symptoms. We know that a lot of the people at TAP have already had their life change dramatically from a stroke. Others, as we talked about for a good long time, with a primary progressive aphasia, one of the frontotemporal dementias. And the ideas that were behind presenting this today was not just to educate people about the signs and symptoms for a stroke that, you know, they may have already had, but so that they can be aware. There are so many challenges, and so many people go, oh, I'm not feeling good, I'm just going to go back to bed, or, you know, they don't recognize those signs. And I feel like this could do such good being out here, both in our webinar and on our live Facebook. I also wanted to say that you're being very, very humble in your introduction to yourself. Just recently, you won a pretty substantial and exciting award. Can you explain that?
I'm trying to rack my memory.
the Caring Star.
Oh, yes, yeah.
Just one of her many talents.
No, I appreciate that. Yeah, that is the Caring Star Award program. So that is an R38 grant award for residents in neurology, family medicine, internal medicine, or psychiatry who have an interest in dementia, Alzheimer's disease, and other geriatric conditions. And what we do is we spend time dedicated to a total of 12 months of research over the span of our 4 years of 3 to 4 years of residency. And my focus is looking at racial disparities in Alzheimer's disease, and in particular, you know, what are some of the mechanisms that may underlie the epigenetic modification for the risk of Alzheimer's disease later in life. So I'm really excited and grateful to have that grant support to pursue my research.
Well, when that research is nice, you know, started and really delve into, we'll have to have you back, because I think that is something that we're really passionate about figuring out, is, you know, how we can serve people in an equitable and full manner. So thank you so much for doing that. And one more thing I want to do about your introduction before we move on, before I'm done bragging about you, is you have a personal tie to neurological impairment. Would you mind sharing that and how that might have changed your vision for your future?
Yes, absolutely. So I have my grandmother passed away about a year ago. She had Alzheimer's disease. And that was something that really played a huge role in my deep interest in Alzheimer's disease and other forms of dementia. And in particular, because my grandmother, she was in Jamaica at the time, and unfortunately didn't have exposure to a lot of the resources that are available to us here in the United States. And so that was another component of it that really solidified my passion for Alzheimer's disease research and advocacy, because I really think it's important to make sure that everyone who's suffering from the disease or other forms of dementia have access to the care and treatment that they deserve.
And I think that your direct caring, right? Direct caregiving to your grandmother is actually going to be something that is, you know, in your medical practice, going to be something that draws people to you, because you can understand and have true empathy for their journey. So
yeah, absolutely. Thank you. Yeah,
of course. So without further ado, again, Dr. Rose has provided some education materials, and we're going to let her get started. So you can go ahead and share the screen.
Sounds good. I'm going to go ahead and share. Okay. And you can all see my screen?
Yes, ma'am. We're all set.
Okay, perfect. So again, I just want to thank you all for being here this evening. It's really nice outside, and I love that it's still bright out there at this time. But right now, we're going to talk about a very important topic that I think is so critical for the community to be well aware of, especially because we're trying to get as much information out there as we can about the importance of recognizing the signs and symptoms of stroke and how you can prevent it, whether or not you've had a stroke. Because we want this information to be disseminated as widely as possible. You can share this with your loved ones, and we hope that you'll feel armed with this important information when you leave tonight. So again, I'm a second-year neurology resident at Duke University Medical Center. We see a lot of patients coming through from other hospitals. We even have patients coming in from Southern Virginia, from a lot of, we have a very wide catchment area. I'm not a stroke physician, but in my 2 years of training already, I've seen many, many people who come in after having suffered a stroke or a TIA, which we'll talk about, which we call a warning sign for a stroke. So we're always educating patients and their loved ones about the importance of how to manage preventing another stroke from occurring, and how they can, when they go home, what they can do to recognize the signs and symptoms of another one potentially happening again. So let's start off by talking about what a stroke is. I'm sure this is something that we're all aware of, but I want to break it down a bit because it's important to get those fundamentals underway. A stroke is a brain attack. When we think about a myocardial infarction, we think heart attack. And a heart attack is similar to a brain attack in that we have a vessel that is supplying a certain part of the brain that gets blocked off by a clot. And what can happen is you can have either what's called an ischemic stroke, which means that the artery supplying that part of the brain is blocked off by a plaque, or you can have a ruptured artery leading to a hemorrhagic stroke. By far, ischemic stroke is the most common type of stroke that we will see. An hemorrhagic stroke or a bleeding stroke is something that that usually happens in the setting of uncontrolled high blood pressure, and we're going to talk about that as part of the modifiable risk factors. But hemorrhagic stroke is less common, very, as you can imagine, very scary, very dangerous, certainly not an outcome that you want to have. Ischemic stroke is also, is just as dangerous. And so that's why it's really important for us to be talking to patients about what they can do to modify a lot of their risk factors. As you grow older, you're inevitably going to be having, in the majority of cases, individuals will have risk factors that will increase their risk of not just a stroke, but many other cardiovascular emergencies from happening. So, as I mentioned, ischemic stroke, a blood vessel that supplies the brain, is blocked. And hemorrhagic stroke, a blood vessel that supplies the brain, either bursts or leaks. And then we can talk about TIA, which is a transient ischemic attack. And sometimes you might hear people refer to this as a mini stroke, but in neurology, we don't like to use that term because it doesn't mean that it doesn't always mean that you actually suffered a stroke, because the definition of a TIA is having symptoms that are consistent with a stroke, but they resolve within a period of 24 hours. When you actually suffer a stroke, those symptoms are permanent. So, but they can improve over time, and that's something that we'll talk about. So we like to call a TIA a warning stroke. And we explain to patients that it is a warning that an actual stroke can occur. And it happens when you have blood flow that gets cut off to in the blood vessel to a certain part of the brain for a certain period of time. But then, the plaque that lodged there either kind of gets pushed through again. And so that is something that we explain to people who come in with these symptoms. And this happens all the time. So why is this so important? Why do we even need to be talking about this? I think it's important for us to try to put numbers behind all of this, because it can help individuals have a broader understanding of why stroke is so incredibly important. It is the 5th leading cause of death in the United States, according to the CDC a couple of years ago. And this is behind heart disease, which is number one, cancer, COVID-19, as well as unintentional injuries, such as accidents, trauma, etc. It's also very important to know that stroke is a leading cause of disability, of serious long-term disability in the United States, also according to the CDC. And this is something that I'm sure I don't need to really explain too much to this particular audience, because, as Maura had mentioned, there are people within watching this webinar now that may have suffered a stroke, or you may know someone who's close to you who had a stroke and is left with some disability from that stroke. I think the scary thing about a stroke is that you have no idea when it will happen, how it will happen, and exactly what symptoms you'll have. In many cases, we can explain to individuals that they are at an increased risk of having a stroke, but of course we can never predict what their stroke is going to look like. You can have a very teeny tiny stroke, let's say in the left front part of your brain, that causes maybe a touch of weakness in your hand and nothing else is affected. But someone else can suffer a more massive stroke, let's say let's say in the left side of their brain, perhaps in the brainstem, let's say not on the left side, but in the brainstem. And because it's such a small area in the brain where there are so many fibers passing through that control eye movements, a lot of our cranial nerves, our strength, you can have massive disability from that. So we have we don't know exactly what a stroke is going to look like, but we do know that it can lead to significant disability for many people. That's why it's so important for us to reiterate this and emphasize the importance of prevention. And every year, nearly 800,000 individuals in the United States have a stroke. And a good number of them, 160,000, will die from stroke-related causes. This is according to the NINDS, the National Institute of Neurological Disorders and Stroke, and the CDC, Centers for Disease Control. And then every 40 seconds, someone in the United States has a stroke. Every 40 seconds, less than a minute, someone is having a stroke. And every 3.5 minutes, someone dies from stroke-related complications. So this is really scary, and I don't mean to instill fear in. I'm sure some of you may be familiar with these statistics, but I just wanted to emphasize the importance of this discussion. So, what are some of the warning signs of a stroke? How can you recognize it, and what should you do as soon as you see these symptoms in a loved one or even in yourself? Some of you may have heard of this mnemonic or the acronym BFAST. In the past, I think we were actually just using FAST, but in recent years, we wanted to incorporate the BE at the beginning to account for certain types of strokes, which we would call posterior circulation strokes, so strokes that can happen in the back of the brain, which is an area that is responsible for eye movements, our coordination, things like that. And for the eye component, as part of BFAST, you can have an eye stroke, or what we call a central retinal artery occlusion. And only recently has it become the standard of care for someone who has sudden onset loss of vision to be sent to the emergency room for a stroke code or stroke alert, and for them to be worked up for a stroke, which is mind-boggling. But BFAST stands for balance. So if you or a loved one suddenly develops loss of balance, you have disequilibrium, you're not walking the way you normally do, and this is all of a sudden, consider, excuse me, consider calling 911 so that the ambulance can come take you to the emergency room for evaluation as a stroke alert. And then, as I mentioned, for eyes, you want to, and for all of these, I should say, if all of these symptoms are occurring suddenly and, 1 second the person is fine and the next second they're completely not themselves, that is even more indicative that this could be a stroke, because when we think about neurological disorders, we're thinking about that we usually like to think about them in terms of a time frame. And in particular, if something is happening all of a sudden, that points more to a vascular cause, vascular meaning the blood vessels that are supplying the brain. Because 1 second a clot is not there, the next second the clot lodges itself into a blood vessel. So for eyes, has the person suddenly lost their vision in one or both of their eyes? For face, this is a big one. Is one side of the face drooping? Is there any asymmetry whatsoever? And if their face is looking off at all to you, especially we like to look at the bottom part of the face. Sometimes the top part can be affected, but if it's not, if they can raise up their eyebrows and you see crinkles in the forehead, that's actually that is actually more concerning than if you were to have the entire side of the face that's weak. This is getting a little bit more in depth, but if the entire face is weak, that tells you that they could be having a stroke, but that actually would also be concerning for something that's not as serious as a stroke, which we would call a cranial nerve 7 palsy. But if the lower part, I want to emphasize, if the lower part of the face, the cheek and the chin, if those are drooping and the forehead is fine, that is even more concerning for a stroke. And then arms, is one arm weaker than the other? Do they have any sensory changes? Are they numb? One way that we actually test this, sometimes we can just do light touch. You touch both sides and you ask if the patient can feel it, if it feels different on both sides. But one way that we try to do this a bit more in depth is we actually get something that's a little sharp, like we might get a piece of, it's called we have a cotton swabs with a wooden stick to it in the hospital. Usually we break the tip in half, and then we poke the person on that side and compare it to the other side. And if they're number, this is even more sensitive for sensory changes. If they're number on the affected side, that's more concerning for possible stroke. S is speech. You want to be keeping an eye or an ear out for this. So dysarthria, slurred speech. Keep in mind if the person all of a sudden had difficulty getting their words out, or in particular, if they have difficulty enunciating their words, that is concerning for dysarthria. It could be a sign of a stroke. Another way that speech can be affected is if they have difficulty getting the words out. They know what they want to say, but they can't get it out. That's concerning for what we would call aphasia, as I'm sure many of you are familiar with. And there are two types that we like to evaluate for. There's expressive aphasia. So as I mentioned, word finding difficulty. They can't get the words out, but they know what they want to say. And then there's also receptive aphasia, where the individual has difficulty interpreting or understanding what is being said to them. For aphasia, A means without, aphasia, language. So literally without language, but basically we use it to say that the person has difficulty with language. And then T is not necessarily a symptom, but it's in there to make sure that we remember that it's time to call 911. If the individual, if your loved one or you yourself have any of these symptoms, it's important to remember to call 911 so the paramedics can take you to the hospital. Okay, so next, let's talk about the risk factors. Let's talk about what we can do to prevent a stroke from occurring for the first time, which is primary prevention, Or from, again, if you had already had a stroke, then we want to talk about secondary prevention. So we like to break up the risk factors by modifiable and non-modifiable. Modifiable meaning that they can be controlled or treated. So the number one thing that we talk about is high blood pressure, because this is actually the largest risk factor for a stroke if it's uncontrolled. The goal, according to the new guidelines per the American Heart Association, is actually less than 130/80. Previously, it was less than 140/90, but we had seen better outcomes in individuals who had a tighter control of their blood pressure over longer periods of time. So this is something that we like to educate patients about, again, because it is the largest risk factor for strokes. And what can happen if we're thinking about the molecular level, the reason why this is so important is because high blood pressure, if it's uncontrolled for many years or chronically, and there's no, the individual's not taking medication or not doing anything to try to improve the high blood pressure, that can, so that pressure kind of pushes up against the blood vessel, and over time can lead to remodeling of the vessel. It can thicken or hypertrophy. And as a result, those changes then lead to plaque formation, and it could also lead to clots breaking off from that plaque to then break off and go into a vessel in the brain, leading to a stroke. So I always try to tell people to, and this is what your primary care provider will also emphasize to you, get a blood pressure monitor. So you can buy these online on Amazon, or there's actually I can't remember the name of the website, but there are blood pressure monitors that are validated by these governing societies that have been tested. They work well, and it's important to check your pressure at least a couple times a day. And if you are persistently above 130/80, it's time to talk to your primary care provider so that they can get you on medication or counsel you on the appropriate lifestyle modifications, like eating better, exercise. That can help keep your pressure down as well. But if that doesn't work, then you would need to be started on medication. That is the safest thing to do. And then we also talk about hyperlipidemia, or high cholesterol. And this, this can happen again over the lifetime, and exacerbated by poor eating habits, unhealthy diet, physical inactivity that can raise your cholesterol levels. In particular, in stroke neurology, we like to look at a specific type of cholesterol called LDL, or lipoprotein density, or lipid density lipoprotein. And we like to make sure that the level is less than 70. If not, then we start patients on a statin, which some of you may have heard of. Oftentimes we start one specific type of statin called atorvastatin, or Crestor, or sorry, Lipitor, to get those levels down. Not everyone needs to be started on it, especially if you never had a stroke. Your LDL levels are great. You don't need to start a statin. Some people can develop side effects to the statin, like muscle aches, and that's the most common side effect, but it's mostly very well tolerated. Next, smoking, of course, or other drug use. Smoking, cigarettes in particular, can lead to, and tobacco. The nicotine from the cigarettes can also affect the blood vessels and incite plaque formation over long periods of time if you smoke. If you have been smoking for many years, so I would strongly urge individuals who are still smoking to stop, or to try to cut back, and certainly talk to your primary care provider about ways that you can try to wean off, such as using nicotine patches or the nicotine gum, whatever you can try to do, because this increases your risk for stroke pretty dramatically as well. Other drug use illicits, we always ask patients, of course, this is, in the clinical setting, we're very non-judgmental. We really just want to make sure that we understand you holistically so that we can better help you. So we ask about illicits like marijuana, heroin, cocaine, because that of course can increase your risk for stroke, not just stroke, but actually cardiac disease. Cocaine in particular can affect the heart, and we've seen that unfortunately more often than we'd like. Diabetes, type 1 or type 2. Make sure that if you do have a history of this, that you are following very carefully with your primary care provider, especially if you are on insulin or any other anti-diabetic medications. You want to make sure that your glucose is being checked regularly, as well as your hemoglobin A1C, which is just a fancy way for us to say that we're checking to see how glycosylated your hemoglobin is, or how much sugar is on your blood cells as it's moving throughout your body. If you have a very high A1C, it is likely that your diabetes is uncontrolled, and that's really not safe for from a stroke standpoint or any other cardiovascular disease standpoint. Physical activity is also something that can be modified, if you will. It's so easy to kind of just spend a lot of our days on the couch, being sedentary, even at work. You know, I personally spend a lot of time at the computer documenting my notes and making sure that everything is in the electronic medical record. So we do spend a lot of time sitting, and oftentimes it's not really our fault. But the more that we are conscious of how much, how sedentary we're being, and the more that we acknowledge the importance of getting up and even just walking for 20 minutes a day, that can make a substantial change in your risk for a future stroke from occurring. So, you know, we recommend about 150 minutes a week. I think it's actually maybe 150 to 175 minutes a week of moderate intensity exercise, which you can do at the gym. And everyone thinks, like, I get on the treadmill, or I have to, you know, do some weightlifting or something that's really intense. I dislike all of that. It's important to keep in mind that you you don't have to do that. You can do what you find enjoyable. So if you enjoy dancing, perhaps take up Zumba, or if you just want to go for a walk, recruit a family member or a friend to walk with you in the early evenings or in the mornings. If you want to get that over with at the beginning of the day, or yoga, something that can be light intensity alone can make a big difference. So anything that you enjoy doing, I highly recommend taking that on. And actually, a fun fact is research has actually shown that the more physical activity you do over time, it can actually lead to growth in our hippocampi, which are a part of the brain that's very important for memory, which I thought was really astounding to hear. So the more that you keep up with the physical activity on a regular basis, the more robust your memory can become over time, which is really cool to learn. Obesity kind of goes in hand with what we just discussed. Modifying your diet. I know this is something that's really hard, especially down here in the South. I've certainly noticed this, particularly in my patient population, but even among my coworkers. You know, it is part of the culture to, and throughout the United States, but I've noticed it a little bit more down here, where we have a fast food place like on every corner. I mean, who doesn't want to go to Bojangles or Chick-fil-A? But it's just a matter of eating those things in moderation and really trying to cut back on your sodium intake, the sugar intake. Some people are a bit more neurotic about measuring, you know, that they're actually only doing two tablespoons of salt a day, or whatever the maximum is that's recommended. But ultimately, just keeping in mind that we need to be eating a lot of these, some of these more fast foods in moderation, and trying to incorporate more color into our diet, more vegetables, fruits. If we're just doing that and really trying to modify that behavior, that can also make big differences later down the road. And then talking to your primary care provider about a special diet, if this is something that's really difficult for you, is something I would recommend. And then atrial fibrillation, I kind of threw that in there, but this is really important because we see this in a lot of our stroke patients. Atrial fibrillation, I'm sure some of you may know what this is, but it's essentially an abnormal rhythm of the heart. So atria is a chamber of the heart, and in many cases, it's the left atrium of the heart. There are 4 chambers. The left atrium is the one that's most commonly affected by AFib or atrial fibrillation. And the reason why it increases our risk for stroke is because when you have this abnormal rhythm of your heart, which can lead to abnormal blood flow, that can then kind of, the theory is that abnormal blood flow that results from the quivering of the atria can lead to clot formation in that part of the heart. And that clot that forms can then go from the left atrium to the left ventricle, and then it would go up to a vessel that supplies the brain. So it's really important that we are monitoring for patients who come in with stroke for the first time or even a second time, and we need to have them on telemetry. So meaning that we need to hook them up and put on these sticky things on their chest to monitor their heart rhythm and look throughout their hospitalization if they develop atrial fibrillation. And if they do, then we need to have a discussion about what we call anticoagulation. So basically, we need to put them on a blood thinner. In many cases, it's Eliquis to prevent those clots from forming. And it's not guaranteed that it will prevent a stroke from occurring, but it certainly reduces the risk. Some of the non-modifiable risk factors, so essentially things that we can't change, we can't really do much about because it's inherent, is our age. We can't get younger. We only go in one direction, unfortunately. And with age, there is inevitably going to be some plaque formation that builds up in our vessels as it becomes older over time. Gender, we can't change the fact that we're a man or we're a woman. The incidence of stroke is actually higher in men than in women in all age classes. So higher in men than women. We can't change our race. Stroke, unfortunately, occurs more often in ethnic minority communities. And the reasons for that are, I think they can be a whole other presentation, but a lot of that is likely due to lifestyle factors, cultural differences, including the type of food that these communities may eat, higher incidence of other cardiovascular risk factors like high blood pressure, diabetes, etc. Family history of stroke can also, if there is a genetic component to the stroke, that could increase the individual's risk of having a stroke. That's something that we can't do anything about. And then having a history of a prior stroke, TIA, or even a heart attack, that increases risk for future strokes from happening, and having that history is something that can't physically be changed. Okay, so when we talk about treatments and management of stroke, we're talking about what happens in the acute setting, so within the first 24 hours of the symptoms happening, and then we would talk about the long term. So just wanted to briefly go through the thought process that happens on our side, on the medical personnel side, when we have an individual coming in with sudden onset, let's say facial droop or arm weakness. Immediately there's concern for a stroke. If it turns out that the patient has a convincing story for a stroke, but we didn't yet quite confirm by imaging that they had a stroke, it's still, and they have no contraindications to TPA, we would still likely push for that. So TPA is a medication that stands for Thrombin Plasminogen Activator. And essentially, it is a medication that we give to individuals who are coming in with symptoms that are that could be consistent with the stroke, that are very, I shouldn't say obvious, but for example, if someone is coming in with symptoms with the right arm, right leg is affected, and they can't get their words out, and the right side of their face is drooping, we're thinking, oh my goodness, they're having a left MCA syndrome. MCA is the middle cerebral artery. It's the most commonly affected artery in a stroke. And so sometimes we call these syndromes. We don't really need imaging actually to tell us that this patient is having a stroke. And if they don't have any contraindications to the TPA, we'll talk to the family. If the patient isn't able to consent, we'll talk to the family about the risks and benefits of the TPA. And then we would administer it within 4.5 hours. If it's beyond that time, then we don't do it because research hasn't really shown benefits beyond that time frame. If we're beyond the 4.5 hours, however, but the patient qualifies for another type of procedure called thrombectomy, where we actually go in, this is the neurosurgeons that go in and physically remove the clot with a device, then we would talk to the family about that. That can lead to remarkable improvements in the patient's symptoms. So I try to emphasize how incredible it is that we have developed so many advancements in the stroke world over the past few years, just since 2015 that we actually started, or 2016, that we really moved forward with thrombectomy, and it's led to remarkable outcomes for patients. So if someone, as I mentioned, that same patient coming in with weakness, complete weakness on the right side of the body, facial weakness on the right, they can't get their words out, their eyes are deviated to the left, that tells us they're having a left MCA syndrome. They qualify for thrombectomy. The neurosurgeon can go in, remove the clot, and we can see hours later, this is what makes this so remarkable, we can see the symptoms get better. What's scary is that if the patient did not come in for evaluation within an appropriate time period, they can be left with those deficits for many, many months and years afterwards because they didn't get any acute intervention. So that's just something I wanted to emphasize that we could do in the immediate setting. And then in the long term, for secondary prevention, we pretty much always recommend that patients take a baby aspirin, 81 milligrams every single day. Sometimes, I don't want to get too nitty gritty here. This is something that we have to be well acquainted with, but just to let you know, sometimes we will also recommend a medication called Plavix or clopidogrel, which the patient will take for 21 days or 90 days, depending on what we determine the cause of their stroke was. A statin, as I mentioned, to help lower their cholesterol, and anticoagulation like Eliquis, which is basically a very strong blood thinner to prevent future strokes from happening. And then, of course, we need to educate individuals about controlling their risk factors, and then following up in the stroke clinic and with their primary care providers so that they are well taken care of in the future to prevent other strokes from happening. Okay, and finally, let's talk about what you as an individual can do to prevent stroke. Number one, exercise. And we kind of already touched on this, the importance of physical activity. Find activities that you enjoy so that you will be more likely to continue doing them. So aim for about 150 minutes of moderate intensity physical activity per week. Research shows that regular exercise can actually lead to the growth of the hippocampus, as I mentioned before, which is so exciting. And that alone is enough for me to want to go to the gym. I also wanted to emphasize the importance, again, of a healthy diet. there is a study called the MIND study that looked at a few different food groups and saw that this led to better outcomes also in terms of memory and in terms of preventing future stroke. So there are 10, in particular, 10 brain healthy food groups that include green leafy vegetables, nuts, berries, beans, whole grains, fish, poultry, olive oil, and red wine is actually on this list, of course, in moderation. And then, of course, limiting or avoiding certain foods, including red meats, butter and stick margarine, cheese, pastries and sweets, and as I mentioned before, fried or fast food. Quit smoking. This is probably one of the most important things you can do. Smoking cessation, if you do smoke, it is so critical to prevent cardiovascular disease and promote better brain health, heart health, every type of health. And if you're having difficulty quitting, talk to your primary care provider about some of the options to help wean you off if you are interested or at that stage. I would also like to talk about going to your doctor, regular checkups. And as I mentioned, I wanted to emphasize in this photo, there's the blood pressure cuff. Blood pressure or high blood pressure is the highest, most important risk factor for a stroke. So if your pressure is consistently above 130/80, make sure that you talk to your provider about what you can do to get that down in the long term. Cognitive stimulation and social interaction are the last two I want to emphasize. Social interaction like volunteering, joining a special interest group, touring at the museum. These are all really important things to help make sure that your brain is awake, it's challenged, taking on things that you've never tried before, that you were always interested in doing. For example, crossword puzzles or learning a new language, something that challenges you that could really help to preserve your cognition at this state is really important in the post-stroke stage as well as in the pre-stroke phase. But I should emphasize that I have it on the list here, but this isn't, I guess, directly isn't really something that would prevent a stroke from happening, but it's something I want to emphasize that you can do if you were to have a stroke and you want to prevent cognitive impairment in the long term, because stroke does increase risk for that. So that is all I have for you this evening. Thank you all so much for your time, and I'll take any questions anyone may have.
Awesome. Okay, can you stop sharing the screen and then we'll pop up together here. Thank you so much. That was it was like taking a mini neurology class, and I really appreciate it, especially during Stroke Awareness Month. So thank you for all the detail. And I know it's hard probably not to go down every road to talk about, but I really love that you are emphasizing that autonomy and self-regulation of blood pressure. And I will find that resource and maybe a couple of options and put them on our Facebook page, where you can get a blood pressure cuff, and maybe even we can teach y'all how if you don't know, but I think they're pretty simple, right? The blood pressure cuffs.
Yeah, and some of them are actually pretty easy. You can put it on your fingertip now. You can actually, there's some that I think go around the wrist that are automated. It's actually much easier now for people to measure their pressures.
Awesome. And I loved, of course, because the Triangle Aphasia Project attempts to reduce social isolation, even amidst COVID, is the social interaction. So vital. And I'm really glad you emphasized that. We did have a couple questions. Could you talk just briefly about carotid dissection? We've had several clients at TAP who have survived, but scarily, a carotid dissection. And if you could just talk about that for a little bit, and then I have some other questions as well.
Sure. Yeah. Thanks for that question. Carotid dissection is certainly something that we look for in patients who come in for the first time with sudden onset symptoms concerning first stroke. We we usually always get a vessel imaging. So we get CTA, CT angiogram to look at the vessels in the neck and in the head, so head and neck, CTA. And sometimes we do discover a dissection where, which essentially means that there is impaired integrity in the wall of the vessel, and some of that blood, instead of moving completely through the vessel, can kind of move into a different part, like within the wall of the vessel. And that alone can increase someone's risk for a stroke because I don't want to get too much in the pathophysiology of it, but essentially some of that wall abnormality in the vessel can lead to plaque formation, and that can cause a stroke. This is something that we would see more commonly in younger patients, especially individuals who may have been playing a sport, they had trauma to the neck, or sometimes actually we might see it in people who had been to the chiropractor and they had like some neck or head manipulation, or even actually one time we saw a patient who she was getting her hair done at the hair salon, and she had her neck back in the sink when they were washing her head, and we determined that was actually a traumatic experience for her carotid artery. So this is something that, if it's determined to be the cause of the individual stroke, the guidelines are to start baby aspirin. We would do antiplatelet therapy to prevent a future stroke from occurring. We don't typically jump to surgical intervention unless it's a truly traumatic dissection that's interfering completely with the blood flow to the brain. Then we would get our neurosurgical colleagues involved. But for the most part, these dissections that we see on our end are they're determined to be chronic, or we determine that it's actually safer to not intervene than to actually get our surgical colleagues on board.
Right. That was really helpful. Thank you. Somebody else was asking about when you were talking about diets, about keto. There's a lot of information now about different types of diets, keto, and do you have any thoughts on that? Because I think the MIND diet, a lot of people are saying, really offers a safe way and a very healthy way to eat. What are your thoughts on that?
Yeah, I have to say, there's a lot of craze about the keto diet. I am most familiar with it from a neurology standpoint. We would recommend the ketogenic diet for individuals who actually have certain types of epilepsy. But in terms of, the mainstream, I admittedly am not very familiar with the mainstream keto diet from a personal perspective. But I know that it's like high fat, low protein, or something like that. I know that there are some health benefits associated with it, but I can't speak too much to the benefits associated with stroke prevention. I'm more familiar with the MIND diet.
Yeah, it reminds me too that there's another TAP talk in the future, is to get a dietitian or nutritionist to tell us more about the MIND diet, but also about, what are some of the crazes that we're hearing, or about what diets are available and what they might mean for somebody who is either doing primary or secondary prevention. When there was a question about medication, and what if you're trying to reduce your cholesterol, but it's not doing enough? Like, when is that conversation appropriate to have with your doctor, where you're saying, I'm doing all these things, but it's not really helping enough?
Yeah, great question. So first line for cholesterol reduction, at least from the stroke perspective, is certainly, oftentimes we throw statins at patients, but we also, of course, need to be, in addition to that, strongly educating about the importance of healthy eating, and exercise, the lifestyle modification. Like nothing can replace that. If that is still not working, even with follow-up labs that are showing that the LDL, that's that one subset of the cholesterol that we focus on, if that is still pretty elevated and above 70, at that point, some of the stroke neurologists may actually want to think about starting another cholesterol lowering medication. And we have many different classes that we like to choose from, including fibrates is another option. But we try to, of course, that's more second or third line medications, but that's something that we would jump to if we're not getting those lipids under control. Again, if we're not getting it under control, we're worried about poor control of this particular risk factor, which can increase risk for stroke.
Right. And I really love how you broke it down to modifiable. And, yes, we have some factors that we can't change, but look at all the ones that you started with. I thought that was great. And I thought that was really appropriate. I think that as we wrap up, and we thank you so much for all of this about preventing strokes and about what a stroke is, and really paying tribute to this month so that we can get that awareness out so people get to the hospital quickly. I think that your BFAST component really reminded us that, don't go back to bed and you're not feeling good, or if you notice any of these symptoms, the sooner the better. But as you know, TAP really thrives on the knowledge that we've gained about neuroplasticity and the exciting implications that has for rehabilitation. And I just wondered if you might be able to speak for a couple minutes on hope, on what happens after a stroke and what does that mean for your life?
Yeah, I love that question, because I think it's so easy to get bogged down in all that stroke does to kind of ruin our spirits. And of course, stroke is something that no one wants to have. But if it does happen, that doesn't mean that it's the end of the world. I want to make sure that people are aware that there are a lot of things that we can do nowadays compared to before. So one important thing I want people to keep in mind is that when a stroke does happen, we think about recovery and improvement in symptoms along the lines of months. So when we counsel individuals, we say that recovery with aggressive physical therapy and occupational therapy and speech therapy, if speech is affected, that improvement will happen most likely over a period of months, not weeks or days, which is what I know people want to hear. But once you adjust that mindset, it's easier to know what to expect and to look forward. I also think that I want people to also feel empowered by some of this information, because as you hinted at, Mara, oftentimes people don't always know what the signs and symptoms are of a stroke, especially, I want people to keep in mind sudden onset. That is very concerning. And it doesn't matter if it's in the middle of the night or you're afraid that you're going to wake someone up. Right. Tell your loved one, call 911. We actually had, I remember this very wonderful patient a few weeks ago who unfortunately had sudden onset symptoms in the middle of the night. He woke up to go to the bathroom and realized he couldn't really move his right leg. And he didn't want to wake his wife up because she had to wake up in a few hours and she was really tired. And he didn't want her to not have a good night's rest before going to work. And so he missed the time frame to come in and get TPA or thrombectomy. And so we told him the importance of needing to wake his wife up so that he could come in for evaluation. This is critical. I think that the way we treat a heart attack sometimes is different from how we treat a stroke or a brain attack. I think that it's just as important. I would argue it's actually more important. If we have our brain affected, that can really affect how we continue living the rest of our lives. So I want people to feel confident now about this information and excited to now share it with your family and other loved ones, so that they can continue to disseminate the information needed to immediately present for evaluation if you develop any symptoms concerning for a stroke.
That's great. I love the message of empowering. Thank you so much for that. And for you all to know too, is that Dr. Rose didn't only offer to help us by presenting about stroke during May, but we had some great conversations about how we can collaborate in the future and how we can better serve populations. And one of the exciting things, as people know about TAP, is that we serve individuals with aphasia, their families, and the community. And we had a great conversation about healthcare providers. And as a resident, how much education did you get about aphasia? What did you learn in medical school or on your in your residency so far about hope with aphasia and how to communicate with somebody who has aphasia, and with doctors having limited time. Those tools and tricks are so important. And Dr. Rose was so gracious to suggest that maybe we could work together on that, right?
Oh yeah, absolutely. I agree. It's very important for us to have a better, as residents in our training, we need to have a better understanding of aphasia, for sure. Mm-hmm.
Yeah. So stay tuned, because Dr. Rose and TAP may be collaborating a little bit to get into those medical school talks or in residency talks, so that we can tell them about aphasia. So you all will have experiences with your physicians that are rewarding. So lots of love being shared on Facebook and on our messages here. I want to thank you all too for taking time. As Dr. Rose says, it's absolutely gorgeous out, and for you to stop and listen to us, it's really appreciated. This will be available also to TAP clients. I'll be sending out this recording, and it is on also Facebook Live. Dr. Rose, thank you so much for your time, your expertise, your passion, and we really look forward to spending more time with you in the future.
Likewise, it's my pleasure. Thank you so much, Maura.
Okay, take care, y'all, and we'll see you next month for June, National Aphasia Awareness Month, and another TAP Talk. So take care, y'all.